Good afternoon, everyone who's joining this. My name's Phil Davis. I'm a Chief Super at Greater Manchester Police, and I'm your chair for this breakout session. So you should be in parallel session 1, which is assessing the mental health and well-being of the emergency responder community in the UK. We have a 20-minute talk from Professor Graham Pike with 10 minutes Q&A. So I'll facilitate the question and answer session and try and keep us on to time. I'd like to introduce Professor Graham Pike from the Open University, who was one of the team led by Gina Harrison who undertook this work. Very much looking forward to this particular session. And Graham, over to you to just give us a flavour of what you've been researching.
Thanks very much, Phil. So I won't repeat my name or title, but just to note that this research was supported by the Royal Foundation, and as well as the police, it crossed all of the emergency services, fire and ambulance, rescue and voluntary services as well. It was conducted by a research team from the King's Centre for Military Health Research at King's College London. And there you see the staff there from left to right, Noah Solomon, Nicola Fear, Mary-Louise Sharp, and staff from the Centre for Policing Research and Learning. Ginny Harrison, smiling on the left there, who is the project lead, myself and Helena King. The report has been published. There's a link in the chat, and you can also click on the link in that slide. And I think you can navigate back to that slide if you want. And I suggest you read the report because I'm really only going to be able to give you a very, very brief taste of everything that's in there. It was very extensive indeed. And indeed, I'm going to not cover two elements of the report at all, which were to do with the families of those working in emergency services and the international context. But very quickly to say that the family stuff is very interesting. And I think our findings were similar to what Andy was just saying about taking problems home. But I think it's an area that needs a lot more research and attention. So definitely worth reading the report for that. So I'm going to be just giving you a brief overview of the research, starting with definitions, and then the methods we used, which were a systematic review, a review of current landscape, and a gap analysis. So I think the primary thing we did perhaps was a systematic review of all of the research, and that started off by looking at some terminology. At the time, the research was really using the term first responder, and that seemed to be what the international context was favouring. It was hard to get the etiology to this, but it seems to be an Americanism that came into favour around the time of 9/11. So we did some research on the terminology and that term, including a CPRL membership meeting where we asked people who they would see that, what terms they would use, what they thought about it. I think there was across the board, all the techniques we used, it was seen as quite a problematic term, particularly that it was exclusive. It excluded lots of people, for instance, COPS officers, some call centre staff. It was problematic for some voluntary services. So it wasn't inclusive enough. And after lots of talking to various stakeholders and different people, we settled on the use of the word of the term emergency responders, and that's the one I'm going to be using throughout the talk. So the systematic review, so this is looking at all the research that's been published so far on a particular area and looking at it systematically, tried to answer the question, what are the most prevalent mental health and wellbeing problems facing UK emergency responders? And I should say that we did this project through 2019 and early 2020, and then of course everything changed with COVID, but we are looking at a pre-COVID world. So the research, we looked at just over 6,000 papers, published articles on that could potentially be about the health and well-being of emergency responders, and found only 81 that had really looked at it directly. And you can see there they crossed a variety of methods. The highest number were about the police, but there were ones about fire staff, ambulance staff, as well as the other services. So this slide is showing some of the output of the systematic review. It's very busy, but that's really because the point I want to make here is that what we found was a very complex, very varied landscape. So there was quite a lot of research going on, and I think on a steepening trajectory. Sorry, I think someone's having some problems with PowerPoint slides. Anita, is steepening trajectory of the amount of research being done. And it covered lots of things like anxiety, depression, and general health, but lots of different measurements and inventories were used that used different cutoffs, that used opportunistic samples. So it was a very busy area. It was very hard to draw general conclusions because of the variation in the types of research methodologies used. And there you can see, though, that some of the studies were finding very high prevalence of mental health problems indeed. So just looking at one area, there was, as you can imagine, a lot of work on the prevalence of post-traumatic stress disorder, PTSD. And even within one particular syndrome, you can see there's lots of different inventories and psychological measurements being used, and they use different methodologies and different sampling procedures. So that even within that, there was a lot of variation. But just to note that the prevalence of PTSD in the UK general population is about 5% for women and about 4% for men. And you can see that the majority of studies on PTSD are finding a much higher prevalence amongst emergency services personnel. Sorry, I'm having some problems with my mouse. The pointer's not moving. Okay, so on basis of the systematic review, there was considerable variation in methodology, which makes it a little bit difficult to draw robust conclusions. And indeed, there was only one study we found that used a representative sample, and that was the police in England and Wales. The others were using opportunistic samples, and we found no cohort studies that would allow you to draw cause and effect conclusions. Though it does seem likely that emergency responders are experiencing more mental health problems, such as depression and anxiety, as well as post-traumatic stress disorder compared to the UK general population. But I think the point that we really want to make here, and which is why it is in bold, and I think that's similar to points we heard from Andy earlier and from Jason yesterday, is that the organisational stressors faced by emergency workers seem to have a greater impact on their health and well-being than did critical incident stressors. So that almost things under the control of the services of the police that could lead to sleepless nights, stress, working at different times, the way people manage those things, those organisational stressors were causing poor mental health and well-being. The good news is, though, that good organisational support, and particularly buy-in from the top and good leadership, did seem to have an effect and did lead to improved well-being, morale and retention. Again, similar to what Andy was just saying in the previous talk. So after the systematic review, we moved on to, rather than looking at the prevalence of mental health and well-being issues, to look at what the current provision is across the emergency services in the UK, or was in 2019, early 2020. And we did this first through first-hand information gathering, through interviews with occupational health, human resources staff and wellbeing leads, and a desk-based review that was partly informed by us talking to stakeholders, talking through those interviews to find where resources online were kept, but basically a desk-based review of all the online resources and provision that were available. So we conducted 40 interviews throughout 2019 that were distributed across the emergency services. Again, quite a busy slide. And again, one of the reasons, rather than reading off individual things, is one of our main findings was there was a lot going on, but immense variation across the board. Now, that was both across services, but also within services. And one of the worrying things we found was considerable variation by geography. So, for instance, one of the interviews with a mountain rescue member of staff said that provision basically stopped at the Scottish border. There was then nothing at England and Wales. But there did seem to be a postcode lottery, even within services, that where you were based led to what type of provision you would get. So the majority of people we talked to mentioned having a framework, though it was far from all. And most of the actual support seemed to be outsourced provision, particularly EAP schemes. The individual initiatives that were mentioned were rarely mentioned by more than 40% of staff, and most were only mentioned by about 10 or 15%. So considerable variation. And one thing to note, and maybe this was a sign of that particular time, was a fifth of all the people we interviewed couldn't provide an example of best practice when it came to current initiatives. Many often said, it's just too early. We haven't got this right yet. So the online landscape was very similar. Again, there was considerable variation. Now, you could say that's across services and across the country. So that doesn't really reflect the experiences of one member of staff going online and trying to find out what resources were available for them. But when we looked at that, that was also seen to be very complex and difficult to navigate for an individual. It was very hard to find information about provision, and where it was being provided by a service, it was usually a link externally. There was heavy reliance on the charity sector, and the charity sector really does vary again by geography. It is worth noting the College of Policing were very proactive on issues of mental health, and they produced a series of educational resources, which I'm sure you all know, downloadable guides on trauma and risk management, as well as e-learning courses. So there were some big initiatives going on, but it really did seem that following the end of the Mind Blue Light Wellbeing Programme, there was a gap in large-scale national provision, with the landscape being dominated by this variation across services, within services, and by geography. Some other things to note of our evaluation of the online landscape. So particularly in policing, few definitions of what mental health issues might be, what well-being was, were provided. Instead, where there was something, it tended to be a list of symptoms, rather than definitions which were then used multiply in different ways. One of the big issues, and something I really perhaps the take-home message from our kind of interpretation of it, was the responsibility for identifying that you had a problem and for identifying support was on the individual. And that's very problematic. I'll talk about this very briefly later on. But relying on an individual member of staff or an officer or whatever to work out that they've got a problem and seek help is not a good model. But that seemed to be the dominant model at the time. I think the other thing to notice was this was a very busy space with lots of going on. There was a lot of provision, but it had really outpaced evaluation. We couldn't find hardly any evaluation. There were in bits and pieces attempts evaluation that were often based on some sort of survey where you asked people that had used that provision what their impression of it was. But there was certainly no RCTs, but there was just generally little evaluation. Okay, my slides are not changing now. So there seems to be a lot of variation in provision, and most of the provision seems to be external. One other thing I think that came out of this was an insight around the importance of culture. Maybe this speaks to organisational resilience and the link between organisation and individual. So again, it wasn't about events being stressful, about the attendance at crime scenes or whatever it was. But one of the things that seemed so important was who your manager was. If you have an unsupportive manager, then your mental health and well-being seemed to suffer. If there was good buy-in from the top, if there was an attempt to do destigmatization, there was an attempt to support people, then mental health and well-being provision seemed to be much better. But culture seemed to be key, both organisation culture, and I think how that then moved also into, often what's called canteen culture, which is the way staff interact with each other. But again, the emphasis here on organisational elements leading to mental health problems rather than this kind of events themselves. We then went to look on what the barriers and facilitators to implementing and using wellbeing support might be. And I won't go through all of these, but just to note again that based on the interviews, one of the issues seemed to be around self-referrals, that where you allow someone to self-refer, that would seem to be a good thing. And one of the barriers was where a manager had to do that. So I was talking previously about somebody relying on an individual identifying their own problems. This is something a bit different. This is where to get a referral to use the provision, you have to speak to your manager. So what staff are reporting there is that's a problem for them. They don't want to go to their manager and admit they're having problems and they're struggling, that they see that that's going to have a negative impact on their career progression. So one of the facilitators was about sharing better practice, and I'm going to come back to that. And again, to note that particularly here in terms of the barriers is stigma. And the complexity and not knowing where to go for help. So this is painting a picture where staff and officers are still feeling that there's a negative stigma attached to mental health and well-being and not wanting to admit to problems. And my mouse has stopped working again. There we go. And that was borne out as well as from the interviews. You prepare everything and then you don't think your mouse can stop working. There we go. As well as the interviews, we found a similar thing by looking research at this area to do with barriers. The research itself also points to issues around confidentiality, about reporting to people that can manage your career, and negative beliefs about how mental health problems will be received by the organisation. And I think it's also worth noting here the research in terms of that ability to an individual recognising they've got a problem has found that the people with the highest rates of PTSD, the people who score the most on alcohol abuse inventories, are the least likely to access services. So there's that belief, you're coping with something yourself, so you don't need to. Relying on individuals to work this out is not a great idea. It's also worth noting that at that point, the UK was a little bit behind several comparable countries, for instance, Canada, in the intentions of emergency responder staff to seek help through MH provision. We then went on to look at some of the gaps in provision. And I think it's fair to say that based on where we were at the time, there just wasn't enough research, wasn't enough being provided for volunteers. They were reliant on the fire, ambulance and police services very often, but struggled to use EAPs and other things. So there was just a very obvious gap in provision. And a launch conference, they spoke very, very passionately about that. There's also, I think, in terms of what our results suggest, there's a great need to support, as well as volunteers, cooperators, and something there seems to be little support on at the moment is for families, for people retiring and those in debt. Very often, obviously, debt is a big cause of stress, and stress can cause debt as well. But debt was hardly mentioned at all in any of the provisions that we came across, and I think that is probably quite a serious gap. There's also perhaps a gap, though I know a lot's been done about that, in providing better line manager training and training for management around well-being and mental health, because really this buy-in from the top and buy-in from your manager is so key in your outcomes and whether you're going to suffer from mental health problems. So based on all of that, and sorry for the whistle-top tour, we made some recommendations, and if you read the report, these recommendations will be much better supported by the evidence and analysis than the very brief tour that I've been able to give you. So the first recommendation was about the term. The first responder is a bit of an Americanism. It was kind of almost jingoistic after 9/11, but it is a problem, and it's a problem because of who it excludes. So we do think that the word emergency responder is more meaningful, inclusive term. And certainly the stakeholders who we liaise with did think we should move away from using the word first responder. So that's a fairly easy one. My mouse has stopped again. OK, so in terms of the research, and I'm going to break these recommendations down in terms of research and in terms of practice. So there were some areas that we could find very little research on. So that included self-harm and suicide, and it included a number of those organisational stresses, which I've been alluding to throughout. So those included things like shift work and sleep. And I think Andy was talking about how his survey, the one being done with Durham, is beginning to pick that up. And CPRL have been doing some work looking at the kind of biological and cognitive impact that shift work has particularly on sleep patterns, and it's not good. So there are some key research that needs to be done there. I've mentioned finance and debt, but again, more research is needing to be done on that. And one of the other things is that, and this tends to be the case in this area of research, there's a big focus on the negative outcomes, what leads to the negative outcomes, and not so much of a focus on the positive outcomes. And research needs to start looking at the models of what leads to a positive outcome. We also couldn't find sufficient research really on a number of subpopulations within the emergency services. So retirees are a key one. That transition from a very full-on job that takes on your life to retirement is something that needs research, and there wasn't much on. There wasn't much research on call operators. Things tended to be on response units. And I said there wasn't much research at all on volunteers, search and rescue. And there wasn't high-risk roles. There was quite a bit on police compared to ambulance and fire. But the one I skipped over and want to come back to, because I think it's particularly important, given many of the conversations we've had after the publication of that report, is the need for research that looks at BAME staff and officers and at LGBTQ. There's very little research, and I don't think we could find any looking at those populations, but some of the interviews we've had and some of the work we've been doing after the publication of that has really suggested that those populations are worthy of research and might be experiencing particularly problematic workplace environments and mental health stressors.
Great. Can I give you your 2-minute warning?
You can, yeah.
Thanks.
I will definitely finish on time. I've started to go a bit slow because I'm nearly on the last slide. Right, so where are we? Recommendations around the research were, I'm not being at all critical of the research that's been done. Those individual studies had very good reasons for using those methodologies, and they had very good reasons for the sampling and the research questions they asked. This is more about the area. The area needs a little bit more coordination, we feel, particularly in using validated mental health measures to allow studies to be drawn together and the use of representative samples. So we would suggest the creation of a research consortium, and I know some efforts are being made in this direction, to bring researchers together. We also think that such research consortium should do exactly what we're doing at the moment and have been doing through CPRL, and I know the college does as well, which is facilitate researchers and practitioners working together. Evaluation, more evaluation is needed, and research needs to help with that. We should look at intervention evaluations. There's precious few studies on that at the moment. But again, I want to finish on the one I skipped over, which is that we need to start looking at research on organisational stressors, as much as, if not more than, the impact of attending scenes of crime, attending suicides, those events. So research is very much needed there. In terms of practice, more support of volunteer roles, retirees and call operators. And I think I've said about that, but those were subpopulations that we identified as needing more help. Sorry, I've lost my place. And the other thing is just to go back to this idea of stigmatization and culture. Those really need tackling. So that can be through promoting, extending support through wellbeing champions. There are a number of destigmatization strategies available, which again use mental health champions. And we need to upskill managers through CPD, because this senior buy-in and fostering culture does seem to be very key indeed. To supporting this around wellbeing issues, and my mouse has quit. And this is the last slide. So in terms of practice recommendations, what we would recommend, and this came out of talking to our stakeholders, was promoting sharing of better practice. This can be done across the sector, as well as between police forces. There's a lot to be said for the services talking to one another. There's lots of good things going on, and it would be good to share. There's a separate report that's available on the CPRL website, if you go to our research section there, on charities. We would encourage collaboration between the charities, and we've been liaising with them and looking into this. At the moment, it is a bit of a postcode lottery. The charities are doing great things, but perhaps a bit of collaboration and more signposting. And one of the ways that I think the police and other services can do signposting, and this is one of our kind of main recommendations, is through the creation of something like a universal gateway website. So this has been done for the military, the Veterans Gateway. So this is a single point of contact for veterans where they can go and helps them engage with charities and other support, rather than having to Google it, talk to people and find it. It seems to have been very successful for veterans. I think bringing all of that information together, given it's already there, wouldn't be that big a deal. But that's one thing we felt would help enormously with practice and provision. And at that point, I'll finish. Thank you very much for listening.
Graham, that was fantastic. Thank you very much for that whistle-stop tour of what is, a very in-depth piece of research. And I would invite all the people on the call to read the report that goes with the talk. So we've got about 9 minutes. I think I'll open up to the floor now for questions. If you can stick up your hands, please, that would be great. And we'll have a short Q&A session with Graham. Any questions at all? Great. While people are thinking, I was just going to ask a question. You mentioned it a couple of times, and that's around the postcode lottery. So have we got a regional issue here that might be linked to anything culturally? I'm just thinking, kind of the north-south divide, that kind of thing. Is there anything we can home in on that postcode lottery?
So I that was something when I was preparing the talk, I was looking into, because I went back and looked at things from a police perspective. I couldn't identify anything as neat as that. What it tends to be, there's a force who often has a champion who's done a lot of work, has liaised with the college, and has created provision, has worked with managers to do it. So it's kind of almost reliant to, and also that the power of the chief and the executive and how much they're buying in. So I couldn't identify anything that was neat. In terms of a north-south divide, there were some forces, and I'm not going to name them because I'll get it wrong, that who were doing a lot. Some that were at that point would acknowledge themselves they were a bit far behind. What I think it points to is simply the need to have much greater sharing between the forces. And I know that's a conclusion that every walk of research with police comes to, sharing better practice between the forces would be really good. That when we presented this work to CPRL membership, they talked about, as well as collaboration with researchers, using forums such as that to bring practitioners together to talk to each other, and sharing better practice is the way to go. Zoe's got a hand up, which is absolutely, because I was just about to mention her. We tried something similar to that when it came to engagement with victims and victim satisfaction, and having all of those leads in the room sharing how they did things and what ideas they had was just such a positive thing. I think lots of people out of. So more of that, really.
I think that's absolutely the way to go, just to share that good knowledge around. So Zoe actually has got a question up in the chat bar, which I'll read out now. So the organisational stresses having a greater impact than the critical incident ones, that finding very interesting. Zoe's wondering if this pattern is found in other professions such as the NHS or universities, for example. If you look wider than that.
Yes, it is.
Right. Okay, Zoe, there's the answer to your question.
So it surprised me, and it would have surprised me a lot more, and this has been recorded, had I not experienced some of this myself. I've been at the Open University a long time, so I've experienced lots of different managerial approaches. So this isn't local. I've always had fantastic line managers, but as an institution, the OU is now being very good about promoting mental health, and wellbeing initiatives. It creates a very different culture. So kind of going through different approaches to management really allow me to experience that. But certainly, anywhere you find shift work, I'm guessing you're going to find this. Anywhere you find poor management or very good management, you will absolutely find this. And I don't know if Paul Wally is here. I don't think he is. But when I've talked to Paul before, who's an expert on the NHS, he says absolutely this is what you find with the NHS as well. It's not necessarily the very difficult patient. It's more the caseload, demand management, how supportive your manager is. Those things drive your stress levels.
Okay. Lindsay Coleman has a question in the chat bar, and she's actually having a conversation with her DCC about this tomorrow, which is good timing for her. Asking how would you advise you approach that conversation with the DCC about bringing in these cultural changes? What are the key things you would want to get across in the room?
I mean, I think simply, I mean, if you look in the report, you should be able to find lots of specific examples and a lot more help, which I'm not going to be able to remember off the top of my head. But I think perhaps the primary thing is to be able to say there does seem to be evidence that's come from objective scientific review that buy-in from the top has a profound effect on the experience of individuals, officers and staff. That I think the police services more or less are still in a position, and this is of course why the Royal Foundation was so good to have involved in this, that the military was years ago, and where the prince, I always forget the name of the princes, the two princes that were part of the Royal Foundation, launched huge campaigns around destigmatizing mental health and wellbeing. There are still elements of that, but it needs to involve from the top. This can't be your sergeant talking to their team going, you know, it's all right to talk about it. This needs to be organisationally led. It needs to have buy-in from the top. I wouldn't underestimate the power of the champions throughout the organisation. If you want, champions are key to change very often, and just having other people whose job it is to champion this, to make sure that, you know, there isn't the stigma, to make sure that there are provisions. The other thing and I think this is my opinion, is one thing to avoid is to have an HR policy or an organisational health policy about what your framework is, but then not have any support. It's, you know, it's no good just being able to say, you know, yeah, we acknowledge this, it's something that we're proactive about, it's something that we want to do something about, without that having some teeth, without being able to say, and if you're feeling stressed, this is what you do. There is this provision. If you're having problems with debt, this is what you do. So it kind of needs, it's not just about the chief saying, you know, I want to acknowledge the problem, let's, you know, I'm open to this. It's about having those mechanisms underneath. You know, yeah, a lot of that is referring people to EAPs and to charities. The more that can be done in-house, the better. The other thing I would say is just be wary of this tension between relying on people to self-refer and requiring them to refer to their manager. So that, I think that's something that needs to be tackled as well. There's just too much evidence that having to talk to your manager, forcing people to talk to your manager if you're having problems, is a real barrier.
Okay, and I think that's a really powerful sentiment to finish on, Graham. And we started a few minutes late, so we finished a few minutes late just to make sure we could give the topic some justice. On behalf of everyone in the group, can I just thank you for giving your time up today to speak about you and your team's work on this. Lots of good questions coming forward on it, and I think it's something that's absolutely fundamental to us going forward in terms of all of the emergency services about looking after our people. So thank you. For the benefit of the group, I think this is the last session of the day. There are no more plenary sessions after this. So thank you all for dialing in for a second day. We've had some fun and games with teams today, but we managed to get through it. And I look forward to seeing some of you, if not all of you, tomorrow morning for the next session. So thank you very much, everybody.